So in my practice, I would say that 95 or greater % of the patients that I treat in my private practice have addiction problems. And so I think the combination of addiction issues or psychiatric issues make it hard to recommend cannabis in good conscience. There are no studies that show that cannabis is effective as a medical treatment for psychiatric conditions or addictions. And so the pain sphere, while I do treat some patients with pain, I would say that I haven't gotten to the point where I've recommended medical cannabis. I think that if a primary care physician is treating a host of conditions, including pain, and working with that patient, there definitely can be circumstances by which you work through a first-line treatment, a second-line treatment, and get to a point where a trial of cannabis makes sense. So in the United States, there are no FDA-approved medications for cannabis use disorder, and so we're working on that. Obviously, Dr. LaFole here at CAMH is working in similar trials, and so I think there's a lot of promise in trying to develop medications for that, but it's something that we need direly because there's so many people out there that do meet criteria for addiction. And as you can imagine, if you, number one, don't think of it as something that could require treatment, you don't think that cannabis is addictive, you don't think that this is something that needs treatment, it's really hard to stop. And then number two, if in fact you do have withdrawal symptoms, and people who use cannabis multiple times a day, every single day, and stop abruptly, they will have anxiety, irritability, difficulty sleeping, and so medications can be helpful. My initial job is just to do what we call motivational interviewing, try to figure out, is there a reason that they might want to, or they may feel the need to reduce or stop their cannabis use. So that's my initial goal, oftentimes, to help them understand that this is something that probably is a problem that requires some treatment. If somebody is working with me beyond that initial evaluation period, I'm again doing more behavioral treatments, and it's what I usually do, what we call cognitive behavioral therapy, where we look specifically at the instances that they're using cannabis on a given day, and these situations vary widely. So getting up, wake and bake first thing in the morning, that's different than somebody who worked all day and came home and views using cannabis as a reward, which is in turn different than somebody who at the end of the night feels like it's the only way they're going to be able to get to sleep. And so all three of those instances requires a different approach to try to understand, is there a physical component there? Is there a withdrawal occurring? Is there some type of psychological component that we need to address? And so cognitive behavioral therapy, or CBT, really does a nice job at addressing those instances. And what you're trying to do is to have people understand why they're doing it, and then also to find alternative strategies for dealing with the reasons that they're using in those circumstances. And again, it's not going to be the same. You're not going to, go at the end of the day, if you're using cannabis as a reward, going out and going for a run isn't going to give you the same effect, but it can be a good proxy. It can be something that you can do that's a bit healthier than using cannabis multiple times a day, if in fact we've determined that your cannabis use is a problem. So I usually will start with motivational interviewing to try to help somebody understand that, that there is an issue. I mean, the reality is, if you've made it to my office, it's probably an issue. And not always, but most of the time it is. And so, like I said, people are ambivalent oftentimes. So you need to move them along a little bit into a point where they would be willing to accept treatment. Once they're willing to accept treatment, and if that for whatever reason they're going to continue to do it with me, then we move into a CBT phase. There are times when we do use medications as well, and that can happen really in one of two circumstances. Somebody can have another diagnosable psychiatric condition like depression or anxiety that might require a medication, or we may opt to use a medication to try to help them reduce their cravings for cannabis. And so there are a number of medications that are used somewhat experimentally for that purpose. Some of those medicines are in the trials that I'm conducting. Research, there's not a lot of research for adults, and there's even less for kids, but I think that if you have a young person in their late teens, let's say, and they're using a lot of cannabis on a daily basis, I think you can use some of the same medications. Obviously, there's more of a discussion with the parents as well. I tend to try to exhaust all their options before I go to medications for cannabis use disorder, especially in young people. But I do think that there are cases where it's helpful. And as I mentioned earlier, a lot of times somebody is using cannabis in a significant way because they have an undiagnosed or undertreated depression or ADHD or anxiety. And so those are things where we have more consensus treatments. You know, if we're going to use a medication to try to treat cannabis withdrawal or cannabis use directly to try to reduce cravings or reduce withdrawal symptoms, two of the medicines that are used are gabapentin, another one is N-acetylcysteine. Again, these are off-label uses, but they're pretty easily tolerable. I think that the medicines that are in some of the trials that I'm doing, cannabinoids like nabilone, and obviously Dr. LaFall has used medicine called nabiximols or Sativex, which is a combination of THC and CBD. Those have higher potential side effect profiles, so they wouldn't be first line in my view. But you know, interestingly enough, cannabis and cannabinoids really have pretty favorable interactions with other medications to this point, and so I think it's pretty safe to do. It obviously needs to be, you need to work with a physician to determine that it's really necessary, but once that determination is made, I think the medicines are pretty tolerable.